This is me. I'm silly Dr. Kelly. I am a double board certified pelvic floor PT. I am board certified in orthopedics, which is how the body moves with muscles, tendons, and ligaments. And then also in pelvic health, which adds in that hormonal component, which is really awesome, and which Ovella is like the dream team that I am like so happy that they exist because they make my life so much better in all the ways. I am a wife, a mom, an athlete, and a goofball. And I have incorporated all of my geekiness into training professionals until 2019, when I really saw a need to reach just people. And because both of my young children were finally in school in 2019, and I had plenty of time, I launched Pelvic Floored, which are online courses. My goals for this talk for today is that you will understand that just doing Kegels is super old news and bad for your pelvic floor, in fact, that you can identify your own pelvic floor anatomy and how it might change over time and what is concerning and that you should get help for and what's maybe normal and we don't need to be worried about. I want you to be empowered with questions to ask your medical providers as you age, and also teach you a few fun exercises for optimal health and pelvic enjoyment. So let's get into it with one of my favorite topics. Just doing Kegels sucks, pretty much, but yet people are still told that. I will still have people show up in my clinic that have been leaking urine for 15 years, and they will say they saw a doctor last year that said, oh, just do Kegels to help fix that. So I want to just give you a bit of a history lesson because it's pretty fascinating. The Kegel itself was invented by a gynecologist named Arnold Kegel in 1948. Picture what kind of phones we had in 1948. Picture what cars we had in 1948. And I am sure that Dr. Kegel was a great man, and I am sure he helped so many people. But he noticed that many vagina owners leaked urine had weak muscles. So he developed this little archaic device called a pereniometer that's like a blood pressure cuff for your vagina. And you would stick it up in your vag and you would go and release. And presumably it helps some people because you got some feedback from this device, right? That study was from 1948. And after that study, nobody else but Dr. Kegel ever used that device, like ever. You can get the little wearable devices, but we'll get to those a little bit later on, sorry. Since then, people just were told to do Kegels. And a study as recent as the 80s found that if we tell 100 people to do Kegels to fix their leaks, half of them are going to do it wrong, and there's going to be no change. A quarter of them are going to do it so wrong that their leaks are actually going to get worse. And only a quarter of them, by sheer luck, are going to get any benefit from it. So that means that since the 80s, we've known medically that telling someone to do Kegels has the same chance of harm as help. And a follow-up study in the 60s showed that we were still just telling ladies this, that 50% of people were not getting any additional information besides just do Kegels. We're still harming people. And as recent as last week, I had someone being just told to do Kegels. So this is still pervasive in the world. And so I need to scream this to you people to the rooftops to know that just doing Kegels is not the answer. And in fact, training someone to do pelvic floor exercises and training them about their pelvic floor is freaking life changing. And that's what we're going to start to do right here today. Now, external anatomy. Before I can teach you those life-changing exercises, we need to know what the parts are. So, in basic terms, if you can see it, it's the vulva. If someone or something is inside it, it's the vagina. Ooh, I love those terms because they just get us oriented and we can communicate better. Is it burning or numb on my right vulvar area? Or is it, you know what? I feel like it's numb on the vulva, but maybe burning inside the vagina. It helps us be a lot more specific. The key areas are the clitoris, which we have the little bulb in the front of the vulva, but there are also two cool arms on either side. And the clitoris is important in sexual function. But my friends, it's also very important in proprioception. Proprioception is what helps me know that my palm is down. I know where that hand is in space. And these clitoral nerves have so much to do with proprioception of the pelvic floor, of telling me where these pelvic floor muscles are in space. And that's really important. So the clitoris is important for sex, which is enough by itself, but it's also important for a lot of other stuff. And it's big. It's not just right there, but there's this whole arm that comes down and over, and it's on both sides. And most vulvas don't have this owie. Your urethra is your pee hole, and that is this little hole. Fun fact, on medical models that are easy to find, on ourself, they're honestly not that easy to find sometimes. And you might even feel like it's up inside your vagina. You have to bring your labia to the side to find this little hole right here. The vulva, remember, if you can see it, it's the vulva. That's kind of these lippy parts. And we're going to talk in the next couple of slides how that changes throughout our life. The vagina is the hole. Again, we're going to talk a little bit about it more in a minute. The perineal body is the space of skin and tissue between the vagina and the anus. And all of that is really important stuff to understand what's normal down here. Now, a question I often get is, Dr. Kelly, am I normal down there? People don't know what a normal vulva looks like. Really, we see a textbook picture, and that is not helpful. So the only way you know what's normal for you is if you look, right? And pelvic professionals recommend you do a self-assessment of the vulvar skin about once a month. You're looking for bumps or lumps, even freckles or moles, just like you would look anywhere else. In my course, Vag Lab, we actually have pictures of a lot of different vulvas. There's a great book or art installation called The Great Wall of Vagina. And yes, it's technically the Great Wall of Vulva, but the Great Wall of Vagina is catchier. And the artist, Paul McCartney, he casts all different vulvas. And it's a really beautiful art project that just shows tons of anatomic variety. And I honestly highly recommend it for anyone who's truly interested to see all realms of what normal is. Age-related changes. People look at an anatomy book and just think, okay, this is what it's supposed to look like. No, I maybe have never once seen something that looks just like an anatomy book. Before our first period, maybe we look like an anatomy book, but then during our childbearing years, which is when we're having regular periods, we might actually have a slight thinning of the labias, but then during our 30s, they're going to get bigger. If we have a baby, oh man, they're going to get really big. They're going to get dark. One might get bigger than the other. Just like our boobs, they're not twins, they're like cousins. And it's totally normal that one might be like massive and the other one is just like totally normal. And here's the thing, they might stay that way. And that's normal. It's not going to cause pain. People who have not had a baby, who are cyclists, if they start developing bicycle seat pain, perineal pain during their 30s or their 40s, if they haven't had babies, they're going to blame their bike seat on it. And usually, actually, it's their pelvic floor, not their bike seat and not their labia. But sometimes they will actually have a surgery to reduce their labia, which is called a labiectomy. And please never, ever do that without doing pelvic PT first, please. Now, in our 40s, estrogen reducing, we might start to notice a reduction in that labia, thinning. We may start to notice any asymmetry reducing. We also may not. Now, but they shouldn't turn whitish and they shouldn't get really stiff. That would be not a normal age-related change. That would be something you would want to talk to your good primary doctors about and say, you know what? The tissue looks white and shiny and it hurts to the touch. That's not normal. Now, in menopause, as we lose estrogen, hopefully not so much as we're working with Dr. Sherman and Baxter, but as we lose estrogen, do we know what estrogen does? A lot of things, but one of the things that helps is plump up our skin. And like my boobs, they're great, but they don't look the same as they did when I was 20, right? Because my collagen has gotten a little bit softer. I'm going to take a couple things out of the pelvis here. Here is the uterus and the vagina. As we lose this collagen, skin everywhere can sag a little bit. The vag can get a little bit thinner. The color of the labia can change. The color of our pubic hair can change. And a lot of these changes are considered normal age-related changes. And if they don't bother us, fine. But if they bother us, that's when we need to talk about, hey, let's get some help. And specifically the thinning of the vag. The same thinning happens to the sweet little urethra, here's your bladder, so pee hole. And as that thinning happens, there's a little less resiliency of these structures. Here's a penis, okay? Look how long. Here's the pelvic floor muscles, and here's the urethra, the pee hole. Goes all the way from the bladder all the way down there to the outside world. Now, a person with a vagina, here's the bladder, and there's the outside world, super small. So as we get this change in collagen, as these tissues get less elastic, the space between the inner and outside world gets a lot less. We can become more prone to urinary tract infections. And one of the greatest things in the last couple of years has been the removal of the black box warning for vaginal estrogen, because applying vaginal estrogen up in here significantly reduces that urinary tract infection risk by plumping up all of these tissues. So I know Dr. Baxter and Dr. Sherman are preaching that from the roofs, but I cannot preach that enough as well, because that is a huge benefit to you to reduce NAP urgency, reduce leaks, and to improve your overall health and actually reduce your risk of death. Okay, now, how do we look at that stuff? To assess your own down there, you'll lean back against a wall or a few pillows and bend your legs up so it's cozy. And you can't really just look. So I recommend taking an old phone that is not connected to the internet in any way. Yes, hitting record, putting the camera down here, and just going up and down and side to side, and maybe even bringing the labia to the sides a little bit. You could use a mirror, but again, it's really hard to see that distance. Do not use any type of shared phone, especially if you're a teacher. There's all sorts of stories about the phones auto-updating. And if you're uncomfortable self-assessing, ask an OB or a pelvic physio to do a little bit of a film assessment when they're assessing you. With your permission, they're happy to do it on your own phone that's not connected to the internet. Then you can hit play and look and figure out what all the parts are. If you have a question, ask your pelvic physio, ask your primary care physician. If they don't know, which again would not be uncommon that they might not know, find someone who does know, because you deserve to know what these different things are. I love teaching about this vaginal and vulvar self-assessments. It is something that is really empowering to women. And a lot of times we've never looked down here. And so without a doubt, the first time we do, we think something's tragically wrong. But usually it's just our parts and we've never known where they're supposed to be before. Side views. Where are all the organs? Here are my sweet, take one step even further back. This is Patty the pelvis. Okay. Your low back is here and your cute little hip bones are here. Your pelvic organs live inside this pelvic bowl, And your pelvic muscles are like a hammock that go and connect the bones from the front to the back and the side to the side. And when we look at them from the side here, your cute little bladder is in front, and then your little urethra, vag and uterus, and then the rectum is in back. In real life, they're a little bit bigger than this, but the relative sizes are the same. So the most interesting thing is the tiny size of that sweet little urethra. The biggest changes in our internal anatomy as we age come with our period, pregnancy, and postpartum phase, and each of those warrant their own specific talk. So for this one, we're going to focus on pee leaks and problems. And specifically, what happens when that vaginal wall can thin, or what happens when the pelvic floor function goes awry. So, if the vaginal wall itself thins, either due to age or due to trauma of childbirth, in the past, we always called this a prolapse, which was a very scary word. And in the newer days, we tend to call it a seal, which is just like a weakening of the wall. And technically, it's always a seal if something's inside, or prolapse if something's outside. More recently, we only call something a prolapse if it's present and it's causing you symptom bother, which is really important. But I want you to understand the differences in that terminology. A rectocele, which is the top picture, is if there's a thinning in the back part of the vagina and the rectum can splooge forward, and that can cause some problems with pooping. It can cause constipation and it can cause poop urgency. A uterine prolapse is when the uterus, which is supposed to be up here, splooges downwards. And then for some reason, I didn't show you a bladder prolapse. That's when the bladder falls down into the anterior wall. They're all very common. And to the point of a recent study looked at 100 college-aged females who had no symptoms. They never had babies. 70%, I think 67% of them had a measurable prolapse on objective exam. And so is the prolapse really the problem? And that's what started to lead us to now we only call it a prolapse if it's there and it's symptom causing. Now, I have other issues with that, which again, we can have a whole nother talk about. Because if it's there, let's strengthen it. Let's do vaginal estrogen. Let's put a pessary up there. Let's help it be better. But anyhow, what you might notice on a self-exam, if it's your uterus that's coming down a little bit, but if this is my vag, I might see a little donut. But that's what, if there's a little circle in my vag, when I bring the labias to the side, that's your cervix. If I pull my labias to the side, and in the front, there's a little striped balloon, that's your bladder. If the striped balloon's a little darker and it's not striped, but if the balloon's a little darker and it's in the back, that can be your bowels and that could be your rectum. And again, this is a little more in depth, but again, I like you just to know what the parts are so you don't freak out. And are we worried if we see those things on an assessment? Does it mean you need surgery? No, it does not. Most vagina owners have some degree of this. Again, my boobs do not look the same as they did 20 years ago. Do I want a boob job? Actually, no. Do I need a boob job? Definitely not. Recent study found over half of those college athletes that had no symptoms had observable change. And 80% of those vagina owners had a measurable change in organ position with just PT that would have been called prolapse. 80% of them had a change that would have been called prolapse 20 years ago. And these are 80% of athletes that have never had a baby. And also, I think 60% of them were leaking pee as well. So these are all dysfunctions that we typically attribute to age, just college age athletes have. So the newer terminology is that seal terminology, and just understand that position of the organ is more likely due to hormonal changes, physical trauma, or poor pressure management. And this is like my favorite thing. Okay, so eyes on me here. My head is your bladder, okay? And my sweet little pelvic floor is an elevator in a 4-story building. It is meant to live on the ground floor, my friends. Okay, we're in Europe, ground floor of a 4-story building. It's meant, my bladder is meant to be supported by collagen and muscles of my tummy and my back and my butt. And my pelvic floor is important, but it's supposed to be down here on the ground floor. And my bladder is happy as a clam here. What if my collagen is not supporting and my tummy is not supporting, and now my pelvic floor is really tight? When I open my labia, what am I going to see? I'm going to see my bladder, and I'm probably going to have pee urgency and pee leaks. But is this a true prolapse or seal, or do I just need to learn to calm down my pelvic floor and use my core properly? And that's so cool. So that's what we're going to teach you. And then that same pressure management is what we do to fix pee problems and poop problems. So since we were on prolapse, we'll just finish that up here. If you actually have one that doesn't respond to PT, surgeries are actually good, 80% success rate with potential complications. But if you tried PT first, there's really a really excellent chance that surgery will be great if PT wasn't able to help you, and surgeons are phenomenal. But just discuss it with your primary care physician and probably get a second opinion to make sure it is truly what you need. Because if you go into surgery like this with the super tight pelvic floor, and then you have the surgery, there could be lots of problems. If you enter the surgery with good pressure balance, it's going to come out much better. Pessaries are cute little things. I used them after my babies, that if there is this true prolapse where the bladder is actually dipping downwards into a weakened area of the vag, a pessary is something that's like a menstrual cup, but different. It goes up and in to take up space and support that weak spot on the vagina, and the pelvic floor can chill and the tummy can do the work. And especially if you have your great vaginal estrogen to help your vaginal wall heal along with it, it's actually required. That will lead to long-term plastic change, it's called, to your vaginal wall. It's a phenomenal tool. But please do try pelvic PT first, because it has the 80% success rate, which is the same as surgery. Okay, now to the good stuff. Of all of those things, what do we have the greatest effect on for pelvic organ prolapse, like risk factors and whatnot? Can we change how fast we age? Can we change what happens at our delivery? We can change pressure management. So in leaks, essentially, if we're going to have normal pee control and poop control, pressure up has to be greater than pressure down. Pressure up mostly comes from the tummy and the butt and the legs, and a little bit, an important bit, but a little bit comes from the pelvic floor. Problems happen when the tummy doesn't do enough and the pelvic floor does too much. What's normal from a pee perspective is we are supposed to pee once every 3 to 4 hours when awake. We should pee for at least 10 seconds. And in between that 3 to 4 hours, when the bladder is half full, it should give us a little whisper that we have to pee. And we should be like, no, I don't gotta pee, girl, hush. And the bladder's like, you're right, you don't have to pee. And it should shut up and continue filling until it's 3/4 full, at which point it should gradually nudge us that we have to pee, and we should eventually listen to it. When the time comes, we should be able to walk to the bathroom, sit down without dribbling, relax our pelvic floor to easily start the pee, easily start and maintain the pee, wipe once, stand up without dribbles, and be done. Cycle resets. We should really not get up at all during the night. Once is allowed after 65 and during pregnancy, but I would actually still prefer 0, to be honest, and you'll see why in a second. Bowel norms. It's normal to poop anywhere from 3 times a day to 3 times a week, as long as it is soft logs passed without urgency or pain, and we never strain. Once we sit on the toilet and we relax the pelvic floor, the colon should push the poop out within 15 to 30 seconds. So just like the uterus pushes your baby out and your bladder pushes your pee out, your colon should push the poop out, not your pelvic muscles. And your job is to relax your pelvic floor to get them out of the way so the poop can come out. And a huge contributor to back pain and to pee leaks is constipation. Whoa. So the best position for pooping and peeing, but mostly pooping, is sitting with our feet passively elevated. So they need to be resting on it. Feet need to be resting on something. Knees a little higher than our hips, leaning slightly forward. We relax our pelvic floor, and then we bear down if we know how, and we're going to practice that in the next couple of slides. And the bearing down is the signal for the bladder or the colon to push the poop out. The stomach should truly be relaxed. In most cases, it should contract gently only if needed for counter pressure for the colon or for particularly hard poops, but that should be like once a month or less. But none of that can happen. Our pelvic floor muscles can't relax. So are we ready to meet our pelvic floor muscles, ladies? I would love if you all had a little rolled towel or a cooch ball or something to sit upon. So if anyone wants to run and grab a hand towel, if you don't want to, then just tune into your space under your down there. In the clinic, before we did this, we would actually touch your pelvic floor muscles. If you so choose to do your own self-assessment, you could touch your own external and internal pelvic floor muscles and say, do they feel rock hard like a brick wall? Do they feel soft and springy like a trampoline? That's the goal. Or does it feel like you could just push for miles? That's a little underactive. That's less common than you'd think, actually. Now, the three connectors that we're going to do are for your diaphragm, your pelvic floor, and your deep abdomen. And I call them the big three. You could do them with a finger in your vag, just one knuckle in, a finger in your butthole, you're so welcome. Or, as most of us will choose today, sitting on a rolled towel or just our seated surface. We want to be attuned to something and to our muscles, and that's what is going to make you successful in this. And it's not going to make me failing because we're actually training you with some biofeedback. So that's how we're going to help you more, girlfriends. Okay. Big three, number one, relaxed breathing. The purpose of this exercise is to connect you to your diaphragm, which is your breathing muscle. In your brain, I want you to picture three light switches. One that controls your diaphragm, your breathing muscle, one that controls your pelvic floor, and one that controls your deep abdomen. Each of those light switches has an unlimited dimmer capacity, and we should be able to use them in any combination. This first exercise talks to the diaphragm or the breathing muscle. We're sitting on the rolled towel or just on our seated surface, and you're tuning in to your pelvic floor muscles. Please put one hand on your lower chest, one hand on your lower belly. Relax your pelvic floor. Breathe in to your lower belly and feel your lower belly expand, but your top hand stays quiet. Exhale, your lower belly rebounds in. Inhale, lower belly gets bigger. Exhale, lower belly rebounds. Your first goal is to keep the top hand quiet. In periods of stress and pain, the body will try to breathe into the chest, and that is not okay. Once you get your breath into the lower belly, now please tune your attention to your pelvic floor muscles. Remember, they are like an elevator that should be on the ground floor of a 4-story building. If those muscles are relaxed, when you breathe in and your belly gets bigger, the pelvic floor muscles should go down to the subbasement. And as you breathe out, they should rebound back to the ground floor. Inhale, belly gets bigger, rectum, vag, and urethra go down towards the subbasement. Exhale, belly gets smaller, rectum, vag, and urethra come back to the ground floor. If you have never learned about your pelvic floor muscles before, if you are having any pain or leaks, 99% chance you are not on the ground floor, you are on the third floor. So you would inhale, belly gets bigger, pelvic floor goes down towards the ground floor. Exhale, belly gets smaller, pelvic floor tries to stay towards the ground floor. Inhale, belly gets bigger, pelvic floor goes down towards the ground floor. Exhale, belly gets smaller, pelvic floor tries to stay down. You're showing your pelvic floor that it can soften and move when you are fully relaxed. And why this is important is how would your hand feel if you made a fist and held it in a fist for the next 3 hours? It would not feel very good. And the only thing that's going to help that is to take the hand out of the fist. I've been a pelvic PT over 20 years. One client in that 20 years had pelvic problems because the pelvic muscles were actually too loose. Everyone else, the muscles were weak because they were too tight all the time. They were in a fist all the time. They were in a wall sit all the time. And so, yes, they're weak when they try to do a Kegel, they can't, but it's not because they're sloppy. It's because they're Kegeling all the freaking time. So this is the single most important exercise, inhaling and relaxing your pelvic floor, and let it take a break when you're sleeping, at least, okay? It's literally going to change your world. There's analogies here. We can picture a pelvic rose. And the reason sitting on something matters is because for most of us, we've been disconnected for a while. So sitting on something gives us a target. And the cooch ball, it honestly is the best. I have a link for you guys. It's $40, but it is the single best investment you can make in your pelvic floor for your ever after. It's designed to go just between your sit bones. And a pool noodle and a rolled towel is okay, but it's not quite the same. And pelvic wands are great. This is a pelvic wand. It can go inside to get to trigger points. But what I find practically is people don't have time or privacy and they question if they're doing it right. So sitting on the cooch ball, you do it for 3 minutes and it's getting the right muscles, whether or not we can feel it or not. So it's a great place to start. Analogies. Inhale, your bottom is a pelvic rose. Inhale, the vag, urethra, and rectum blossom. Exhale, keep them blossomed. And we're never pushing, but we're just keeping them blossomed. Okay. We already talked about the elevator up and down. And if you're not having any pain, yes, the rose can open with the inhale and close with the exhale. If you're not having any leaks, the elevator can go down with the inhale and come back to the ground floor with the exhale. But most people that I see are having problems. So with the relaxed breath, we cue relax with the inhale and keep it relaxed with the exhale. Now we're going to teach you Kegels now. If you know that you have a condition called interstitial cystitis, the best evidence teaches us that we should not have you do Kegels at all, even if we're doing it to relax your pelvic floor. So we would just have you spend the extra minute on the relaxed breath. I don't necessarily agree with this recommendation, but there is evidence to support it, so I'm obliged to share that. Those of you without interstitial cystitis, tune into your Speedo parts, your bikini parts. Kegel, which is lifting the pee parts in like we're holding in pee and the poop parts in like we're holding in a fart, trying to still breathe, hold that up away from our seated surface for 3, 2, 1, and relax that back down for 3, 2, 1. And now, even though we hopefully didn't tighten our tummy, deliberately relax your tummy and take 2 of those soft tummy breaths. Oh, I relaxed more of my pelvic floor when I relaxed my tummy. Oh, that's interesting. Let's try that again. That means that maybe my pelvic floor, I didn't have good ability to turn it off on its own. Let's try again using just the pelvic floor parts. Lift the rectum, vag, and urethra up and away and still breathe. Hold that for 3, 2, 1. Now allow them to settle back down. Oh my gosh, I did so much better that time. And take 2 belly breaths. Good job. And if you happen to still feel an additional letting down with those belly breaths, don't feel bad. A lot of my clients take a couple weeks with this to figure out how to let down. But this ability, people can Kegel. People don't know how to set the Kegel back down automatically. And that's the big thing that we need to retrain the brain to do. You would repeat this a total of 3 to 5 times. And once that becomes easy to do while still breathing, then we would add in, here was the Kegel up to that 4th floor, and we relaxed back down to the ground floor. Now from here, is there an extra range that you could push from just the pelvic floor, not from your tummy? Start a fart for 3, 2, 1, and relax. And here's my absolute favorite analogy. Are you ready? Okay. Start normal. Okay. Drink some chocolate milk from the vag, urethra, and rectum. Hold this, drinking it for 3, 2, 1. Stop drinking the chocolate milk. Relax the Kegel. 3, 2, 1. Beautiful. Keep your belly relaxed. Do not push with your belly. Just with your pelvic muscles, blow bubbles in your chocolate milk. You're so welcome, but it's so good. Good job. Now, studies show if we just tell you to bear down, most people, 80%, actually Kegel when they think they're bearing down. And that's why people can't poop. But now that you have some semblance of what direction is up, even if you can't really make it move down yet, your brain is already moving in that direction. And this basic big 3, this relaxed breath, the Kegel and relax, and the final one right here, supported breath. If you could practice them, if you're having problems once a day, if you're just interested in optimal pelvic health 2 or 3 times a week, you will be amazed at how much better you get. Okay, final one. So we've done the relaxed breath to teach our pelvic floor to chill when we're relaxing. We've done the Kegel and relax to help our brain figure out where the pelvic floor is. But most of the day, we're not totally relaxed. Most of the day, we're doing something. So supported breathing is teaching our brain the difference between our tummy and our diaphragm and our tummy and our pelvic floor. Challenge 1, find a muscle between your belly button and your pubic bone right here. Draw this lowest tummy muscle gently inwards, like 5%, and still breathe. Breathe into your lower rib cage. Okay. Your diaphragm is different than your deep tummy. Pretty cool, huh? Good job. Relax everything. How hard was that? When that's really hard, that's enough for supported breathing. And you would just start there until that was easier. That's showing your brain that your tummy can work to support your low back while your diaphragm is still free to breathe. And that's really important because if it can't do that and I'm carrying something heavy, then it's going to turn off my tummy while I'm carrying that heavy thing and I might hurt my back. Coup de grace, relax your pelvic floor. Keep your pelvic floor relaxed while you draw that tummy in. And now still breathe. And you totally can do it. I know, mind blown. And then even get meaner and say, now from here, Kegel, and then relax. But that's the whole shebang. This is the full shebang. Everything's relaxed. I get out of the car. I start walking. My abs should be firing. My pelvic floor is mostly relaxed. It's probably on the 1st floor. But now I go up the hill. It's harder. My pelvic floor needs to do some more. But now I'm at the top of the hill, my pelvic floor gets to chill again. So these are all motor plans that my brain needs access to, and it should do it automatically, but it won't do it like it can't on its own. But just by doing these big 3 simple exercises, it will.